All right, so let's talk about risk to providers. Failure to clearly and appropriately establish when MMI has been released will inevitably result in billing for maintenance and supportive care. In audits of these records, the number one reason for payer audits and demands for repayment from chiropractors are due to inappropriate billing for maintenance and supportive care. This is a slow pitch as far as I'm concerned, moving these patients forward. But failure to clearly, appropriately establish when MMI has been reached results in billing for maintenance supportive care visits, which may result in audits by the contracted payers and Medicare for that matter, and demands for repayment. So if they deny it, then, you also, but this is the thing. I want to step back on that a little bit. When you have released the patient, the patient's MMI, and you're releasing them, and you and I know it's a maintenance visit, you also need them to sign that waiver too. So even if you don't sign the waiver, if the patient doesn't sign the waiver and you bill that service, they're not responsible to pay that service if it's denied. So you got to have that waiver signed. All right? So we'll talk about that more at the end of the day. I would say, again, if that's happening often in your practice, you got to figure out how to re-manage your patients, because if you're doing it up front and at least talking about it along the way, we very infrequently have that conversation. I wouldn't say we never have it, but I'd say it's an infrequent thing, and it moves pretty smoothly.
Dr. Sharp, I might add to that doctor's comment that it could be to your advantage to keep a copy of the corporate medical policies nearby and show the patient what the corporate medical policy states. And when you say your progress has ceased, they're going to see that they fit into that different category, which is now a non-covered service.
But we don't want you to have to argue with them. If they want you to bill it, as Dr. Sharp said, get them to sign the non-covered waiver and bill it all day long. And they're going to see very quickly that you are correct, that in fact they're not going to pay it.
So this is an interesting, I better be careful because it's be on videotape. All right. My S8990 code, what I charge for that is substantial enough that when it is denied, how do I want to say this? So when because when that code is denied, all right? Well, let's put it this way. You just need to have a cash code that supports that date of service, the care you're providing for that date of service. So when you are establishing what you're going to bill that S8990 code, make sure it's an appropriate figure for that. If it's denied code, then they can see that's being denied, and then you're billing for your cash visit in that case. But they've got to sign off on that waiver. Okay?
Well, and I'm not sure if this is the right time, but just had a conversation recently about this. So it might be worth noting that you probably already do, but you should have set fees for your maintenance, and you can actually have several different fees. For example, you could have a fee, I'm just going to throw out a number, of $50 that just indicated, let's say, a 1 to 2 region manipulation. And maybe you have another cash fee of $70 that involves more regions and a therapy. Okay? These are cash fees. It's entirely up to you how you set those. Okay? So, and another issue is, as that's shared with the patient, more often than not, the reason they want you to continue to bill their insurance is so they don't have to pay.
Right.
But unfortunately, we do have high copays, and often your cash visit isn't even as high as the copay is. Correct?
Yes, absolutely.
So, but I just think it's important to note that physician offices can have multiple fees associated with your maintenance and therapy. That's up to you.
Right. The only thing I would emphasize about that is you don't have that based on a CPT code.
No,
So you could
absolutely
have
not.
your cash fee 1, cash fee 2, cash fee 12, you know,
We
as long as
actually-
they're not attached to a CPT code.
That's correct. We actually just helped a doctor. They were redoing their cash fees, and obviously we are not going, H&S is not going to suggest what a doctor should charge, but they had, as I was saying, they had certain maintenance patients where it only involved a 1 to 2 region adjustment.
Right.
One that involved 3 to 4, one that involved simply manipulation and one therapy, one that involved manipulation and therapy and massage, and she set 4 different fees.
Well, I'm starting to glaze over, and
And-
that's way too
well,
much for
but-
me to remember.
Well, the reason that that is important, particularly for you folks
Yeah.
in this geographic area where we've got a lot of employer groups that cover maintenance, you probably know that those self-funded plans pay a percentage of billed charges. Okay? They pay a percentage of billed charges. So if they're paying 60% of bill charges and you bill $100, you're going to get 60. If you bill 150, you're going to get a lot more, right? But
Right.
you can't have a different cash fee for your self-funded plan than you have for your true cash
Right.
patient.
True.
So it's something that particularly if you're in a region like the Triangle where there are a lot of employer groups, I would really encourage you to take some time and make sure you've developed a good fee schedule for your maintenance patients that are fair to the patient, but most importantly reflect what you're billing. I mean, what services you're providing so that you're reasonably reimbursed.
Yeah, so this is all very good, and I hope you're listening to this because this is where the business of chiropractic starts kind of pushing its way through the way you code and you manage patients. I'll get to you in just a sec, Doc. This is the other thing I would say. For those $5,000 deductibles that are coming into your office, that most of you just say, we're just going to put them in cash. We're not going to go through the hassle of billing them for. And we'll talk about this later today, but let me tell you, these patients convert to maintenance patients very easily because they're used to paying $68, $70 a visit because that's what the allowed is that you're billing for and re-exams and that kind of thing. And all of a sudden you're going to a cash visit and it's $60 for a cash visit and they feel like they're getting a discount. So again, you make business decisions. Well, in this case, when somebody comes and there's a deductible, then you're contractually obligated to bill for those alloweds. Then you get to that point where it really starts working in to help you build your maintenance practice with those patients. So anyways, we could sit around the bar and talk about that for a long time because there's a lot of things that help you see patients and you're more worried about what they're paying than they are worried about paying. But Doc. As long as you're billing that S8990 code, it has no effect on, it doesn't have a negative effect on that. In fact, in the CPRs, you can see they subtract those votes, those numbers right off that top. Yeah, that's a good point because that's not the first time I've heard that question. So the question is, if I'm billing that S8990 code, is it going to affect my profile with H&S? And the answer is no. Okay, good, good. Anything else? All right, audits of healthcare records. Again, that number one reason for payer audits is the inappropriate billing for maintenance supportive care. So this was that study that was done by CMS. This is a little outdated, but the changes in the latest OIG report are not much different. Still, CMS should, the executive summary of this, it was said that CMS should use targeted tactics to curb questionable and inappropriate payments for chiropractic services. I did an entire 1-hour presentation on this OIG report at NCLC 2 years ago, and it breaks it down to the percentage of chiropractors that are billing for maintenance care and all that. There's actually a somewhat small group, but still it's pervasive. So in 2013, 76 million in Medicare payments for chiropractic services were questionable. $76 million. Almost half of the questionable payments were for claims suggestive of maintenance care. And lastly, Medicare inappropriately paid $21 million for chiropractic services that lacked even a primary diagnosis covered by Medicare. So just the basics. I can't believe they were paid that. But you know, that's almost $1 billion that was paid inappropriately on chiropractic claims. Had you asked me, not $1 billion, $100 million is what I meant to say. Had you asked me that there were $100 million in chiropractic claims even being paid out every year, I would have said probably not, but it's substantially more than that. So healthcare records, which have been audited by H&S and payers of those few providers on probationary status with H&S, reflect billing for maintenance and supportive care. So it's just an issue. And again, the only reason it's an issue is you're not following through, doing all the things we were talking about, and you're not making decisions based on clinical information. You're making decisions based on a feeling, and then that's not working for you. So again, take the pressure off yourself. Start looking at those outcome assessment forms. So when you see those patients leveling off or they're becoming asymptomatic, then you've got to move them off of active care plan. So minimize and eliminate the risk. Develop reasonable, objective, measurable treatment goals. Use OAs to establish your baseline at the first visit. Do them at your re-exams and progress exams to gauge your effectiveness of treatment, and make sure you're determining when MMI has been reached, and then properly release the patient from active care.